All right, go ahead, guys.
All right, so our presentation today is on ginkgo biloba. You can go ahead and go to the next slide. Oh, it's all messed up. Sorry about that. Okay, so some things that it is just generally used for, it's used to prevent altitude sickness. It's used for vascular insufficiency, cognitive disorders such as dementia and Alzheimer's. It can help with dizziness and vertigo. It can help with the macular degeneration and glaucoma. For premenstrual syndrome, for SSRI-induced sexual dysfunction, and it is also used as a vasodilator. So it's put in the drug class of neurology and psychiatry herbals. Sorry. So you can go to the next one. So ginkgo biloba is very old. So it was first used as a food source in 206 BC to 220 AD. This is the earliest evidence they have of it. And the seeds were often compared to walnuts. So it was first used and noted as a herbal supplement in 1280 to 1368 in China. And then it quickly spread across China. And its first use was for head sores and the treatment of freckles. And then it was also used for, like I said in the previous slide, cognitive benefits, as well as to alleviate symptoms of asthma. And it is believed to have strengthening properties. So just that picture down there, this is just a fun fact that this tree was actually 1.1 kilometers from the blast in Hiroshima, and the tree survived. So then they built a temple around it, and then soon after the tree began to bud again. So these trees can live for a long time. And then you can go to the next one. All right, so ginkgo biloba is a herbal product. So it's derived from plants. It is used to improve health and the well-being. It's often seen as safe because it is natural. You can say it's derived from a tree. However, it still needs to be taken with some precautions because it can still have adverse effects, and it can interact when it's taken with other drugs and supplements. You can go to the next.
Okay, so this one was one of my slides, and just to preface this, my dog is snoring in the background, so I'm really sorry if you guys can hear him. So I kind of was trying to compare and contrast the medicinal therapies, or like the therapies with the ginkgo biloba and actual medicine. But one of the, I think, just the most important things is to not mix them without your doctor knowing. So things that sometimes medicine doesn't do that the ginkgo biloba does is listed under the pros, which is improved circulation, increases metabolism, helps blood vessels relax, and prevents cholesterol from turning into plaque, improves eyesight, muscle cramp relief, and decreases liver damage. But then some of the cons is it can cause headaches and GI disorders because of the antiplatelet properties that it has. And I mean, with anything, you can have an allergic reaction. So you can't usually get all of the therapeutic effects that ginkgo biloba has with just one pill in like the medication world and like the pharmacological world. But the pharmacological world does regulate their stuff and have lots of studies and stuff, so we usually know a little bit more about what we're taking than if it's just like an herb that's like a supplement. And you can go to the next slide. So the interactions that kind of come along with ginkgo biloba is because it's an antiplatelet, you shouldn't combine it with things that don't go well with antiplatelets like ibuprofen, and other anticoagulant or antiplatelet medications, because then you're just gonna like double up on that, and that's not gonna be good if you fall or you have some type of accident. And then it does reduce the effects of a lot of medications. The source I found didn't cite or didn't specify on the diabetes medications. It just said diabetic medications, and then some statin drugs, like Lipitor, Zocor, and then antidepressants such as Prozac and the tofranol. And then it also specifically said alazapram or Xanax, which isn't an antidepressant necessarily. It's more like an anti-anxiety. So it definitely has effects on other prescription medications. And then you can go to the next slide.
All right. So the active substances. So the first one, ginkgoloids. So they are antagonists of platelet activating factor. So just like Brooke said, making sure you're not taking it with those medications. So it has flavones, which protect the brain. This is where it comes in to help, like how they believe it helps with memory and dementia. So it protects the brain through antioxidation, modulation of signaling cascades, gene expression, and it also has an anti-inflammatory action. And then the last, the bilbobalades, it has neuroprotective effects, and it also induces liver enzymes and things.
Okay, so with dosing of ginkgo biloba, so it has kind of standardized. So the source that I found showed these following dosages that are recommended. So the first one is 180 milligrams a day. This showed cognitive benefits in healthy patients in a clinical study they did. 240 milligrams a day does show therapeutic benefits with pain relief, was an added benefit that they mentioned in that study. And then, so the current recommended dose is between 120 to 240. They recommend splitting it in between 2 and 3 doses per day. And then another side note, for patients taking this for peripheral vascular disease or tinnitus, they didn't recommend more than 160 milligrams in, again, those 2 to 3 doses per day. And just kind of a fun fact or something you could include with patient education is that this CAM is pretty affordable. So for 120 milligrams, for like about a month, it's $15 to $20. And then if you want to go to the next slide. So Googling just like different forms of this, there was a ton of stuff that popped up. So it is available probably in any route that you possibly can take a medication. But these were some of the more popular ones I was able to find. So you have your kind of standard, just extra strength supplemental pills. That green one is a combination of ginkgo biloba and turmeric for healthy joint support. I also found a facial serum that soothes and calms your skin. I found some serums that you can take orally as well. And then ginkgo and ginseng, that's how you say that, has anti-inflammatory effects. And then the last one is actually Eucerin brand. So that was a common brand. I was kind of curious to see that they had something that involved this supplement, but it's ginkgo and ursolic acid, and it has anti-aging, anti-wrinkle kind of contour benefits. And then next slide. Okay, I can do our learning activities. So we are going to have you guys just type your answers in the chat box. We just have some NCLEX style questions if you want to go to the next slide. Okay, so ginkgo biloba can be used to treat everything but which condition? A, diabetes, B, altitude sickness, C, memory loss, or D, asthma. Go ahead and type your answers. Give you a minute. A. Everybody is saying A. That's correct. Go to the next slide. Diabetes. And the next one, we have another question. Okay, what was the first country to adopt and use ginkgo for medicinal purposes? Germany, the US, China, or Japan? Everyone is saying C, China. That is correct. Okay, and what are the active substances in ginkgo biloba? So are they bilbobalides, ginkgo glides, flavones, or all of the above? Okay, so I'm seeing some mixed answers. I'm seeing C, B, and D. So it's actually D. All of them are active substances in ginkgo. And then those are our references.
That last question I thought would be a good question because I personally thought that a lot of like the bilobili whatever and the ginkgoids that sounded like made up stuff. So that's what that's what I thought was kind of like a just kind of like a good thing to know about it. So yeah, anyway.
Okay, good job, guys. Let me get my PowerPoint ready. Okay. All right. Solid work. Okay, so this week, let me turn on my. Okay. So this week we're going to talk about some neurodegenerative disorders and seizures. That's kind of loud. Okay, so we're going to talk about Parkinson's and Alzheimer's. This is chapter 20 in your book. And then we did cover a tiny bit the last week on page 217 to 219. That's the benchtropine drug that we covered. So that's where you find all the information. And then here's your learning objectives that we're going to go over. Hopefully meet all of them. Okay. So quick review of pathophysiology of Parkinson's disease. So the function of the basal ganglia in your brain, in your head, is to make movement smooth and coordinated. So our brains are really cool in balancing these neurotransmitters so that we have nice, even, very coordinated movements. Okay, it also affects our posture and our walking, stuff like that. Now, the basal ganglia releases dopamine, which is the neurotransmitter there. And in Parkinson's disease, for some reason, the dopamine just is messed up. Okay. It kind of like the nerve endings degenerate. And it's part of the basal ganglia called the substantia nigra. And there's kind of the picture right there. You can kind of see where that is sticking in the middle of your brain. So what dopamine does is it helps decrease those tremors and okay, yeah, so when we have dopamine, it decreases the tremors, it helps with our posture, it helps just keep everything nice and evenly flowing. When we have problems with the dopamine in our brain, that's when we start having problems. Okay, we don't know why. It's unexplained. There's no cure. It's progressive. It's chronic. And like you see here, this is where all of us are right here. Our acetylcholine and our dopamine are nice and balanced. We can write well, we can talk well, we can walk, we can, move our fingers, we can stop moving, we can do all that thing because it's nicely balanced. Our brain just does it for us. Now down here, this is more of a Parkinson's disease balance in their brain with the neurotransmitters. Their acetylcholine is really high, their dopamine's really low, there's no balance. And so they start tremoring, they have slow movements. We're going to talk about their symptoms here in a hot minute. Now this disease is a rule out disease. We call it a rule out disease. It's something that they don't have a specific test for. They can't just take your blood and say, oh yeah, it came back positive for Parkinson's. What they do is they rule everything else out. They say, okay, we think it might be this problem. We think it might be that problem. We think it might be that problem. And when they start ruling all those out, and the last thing is Parkinson's, that's how you get your diagnosis. Okay, so here's some of the manifestations of Parkinson's disease. We have the muscle rigidity, loss of voluntary movement, bradykinesia, which is slow movements, tremors at rest, and the most common one is a pill rolling. They'll sit there and do this with their hands. Let's see, what's the best? This way. They'll do this with their hands, just over and over, and they call it pill rolling because it looks like you're rolling a pill in your fingers, right? So that's what you're gonna see with that. And then disturbances in posture and balance. So they're gonna be leaning over, they're gonna have a shuffle gait, and then all this is just all kind of slowed down. So those are the symptoms you're going to see. Also with their face, they're going to start having like a flat effect. They're not going to be able to show emotion very well. There's a couple different types of Parkinsonisms that can happen. So we have our regular Parkinson's disease. We just focused on right here with the degeneration of the dopaminergic neurons, right? And the lack of dopamine. So that's, like we said, a chronic progressive disease. There's no cure. It goes. Other things is we have the pseudo-Parkinsonism. And this is caused by different things. Pseudo-Parkinsonism, pseudo means kind of fake, right? So it's kind of like a fake Parkinsonism. So a couple things can make this happen. You can have drug adverse reactions, and there's a couple of medications. There's a few more, but a couple of medications that can cause pseudo-Parkinsonism. Different poisons, carbon monoxide, manganese poisoning, they can manifest symptoms of Parkinsonism. And then different disorders can do this, can cause these kind of symptoms. Now with these three right here, the drugs, poisons, and disorders, those, if you, obviously, if you change drugs or stop the drug, if you get the poisons out of your system, and some disorders, depending on how they're treated, those, if you change that, the Parkinsonism is reversible. The symptoms go away. This one right here, the Parkinson's disease, is chronic. There's no cure, it won't go away. But these ones, you can fix the symptoms, and the symptoms will go away. Okay, so understanding that it is a chronic progressive disease with no cure, there are still some non-pharmacological ways to help a patient with Parkinsonism. The first one is patient teaching. I am a huge fan of the saying, knowledge is power. It absolutely is. So if you are able to either teach the patient or get them resources that they can use and need, and they have a good knowledge of this disease, it will absolutely help them manage it better. Different forms of exercise can help. Changing some nutrition can help, and then definitely group support, and not just for the patient, but group support for the caregivers as well. This can be a pretty stressful disease, and so helping those caregivers have support definitely helps as well. And then like I said before, the pseudo-Parkinsonism due to drugs, poisons, and some diseases is reversible. Antipsychotic drugs are high in giving pseudo-Parkinsonism symptoms. Okay, so there's a couple different categories of drugs or classifications of drugs to treat Parkinson's disease. We have our anticholinergics, which we covered last week, so you all know what those do, right? They block the cholinergic receptors and reduce the acetylcholine in there. We have dopamine replacements that convert levodopa to dopamine. We're going to talk about those. Dopamine agonists. So they stimulate the dopamine receptors. The monoamine oxidase B, MAO-B inhibitors, right? So it inhibits the MAO-B, which is the enzyme that interferes with dopamine, inhibits that. And then we have the catechol-O methyltransferase, or we call them COMTs. That's just an easier way to say it, COMT inhibitors. And that's another enzyme that interferes with dopamine. And so that just inhibits those enzymes to help increase the dopamine. Okay, so with all of these medications, you can get what's called wearing off effects. So initially when people take a lot of these medications, especially if it's caught early, the symptoms are well controlled, they see a lot of benefits. And after a few years, some medications you develop a tolerance for. And so it gets to where you take the medicine and your symptoms are controlled, but then it doesn't last as long. And so then your symptoms come back before the next dose is due. So that's called wearing off effects, right? And the on refers to when the medication is working, off refers to when the medication is worn off. So if you have a patient that that you're seeing maybe in a clinic or something, and he's like, yeah, you know, this used to work really well for me, and now I'm noticing like I'm starting to get hand tremors before my next dose and stuff. What kind of things are you going to do with that information, do you think? Right, Megan, change the dosage. But can you do that as a nurse? No, so you're going to notify the doctor. Okay, but yeah, the dose will definitely be changed. So they'll either need to increase the dose, maybe add another medication on top. Maybe, you know, if they're maxed out on some medications, they'll take that away and put other medications. So definitely this is something that, you know, if you're starting to hear your patient or a client or somebody start complaining of returning symptoms, you'll definitely want to talk to the doctor to get a different dose. With it being a progressive disease, the dosages are going to change quite often. You're going to have to be changing those dosages and medications quite often because it's just going to progress. Okay, so anticholinergics. They block the cholinergic receptors, right, reducing the acetylcholine. So with our high acetylcholine, sorry, I got to get my camera right, and the low doses of dopamine, if we're reducing that acetylcholine, we're going to get in a little bit more balance. Okay, it helps with the rigidity and tremors because our acetylcholine isn't so out of balance with our dopamine. Now, these types of medications don't help with bradykinesia. That's the slow movement, right? And then, as with any cholinergic medication, we have all those good side effects. And with these types of meds, the dry mouth, photophobia are going to be probably the biggest ones. You're going to have the other ones as well, though, like the urine retention and all this stuff. So it's probably, I mean, knowing that, so knowing all of those side effects, what type of things would you maybe tell your patient if they're put on an anticholinergic medication as far as teaching goes? Like besides like if you say, okay, it's going to cause dry mouth and urine retention and photophobia, and they're like, okay, great, but like tell me how I'm going to manage this. You guys have any ideas on? So this is the type of thinking like with the test, right? Because it's going to say a patient is, put on these anticholinergic meds. What type of teaching are you going to give? And it's going to, right, Megan, like great, like that could be one of the options, like have them have water with them or suck on ice or suck on hard candy, right? Right, Olivia, right on the same time. Yeah, wear sunscreen, long sleeve clothes, sunglasses. Now, as far as urine retention goes, it's not going to change. I mean, your urine retention is going to be there whether you have, 900 mils in your bladder or 200 mils in your bladder. So as far as drinking water and trying to increase fluids for urine retention, that's not necessarily going to work. It will help with the dry mouth for sure. If you're drinking, a lot of water and swishing or sucking on ice or doing whatever, definitely help the dry mouth. Things that will help urine retention, maybe, going to the bathroom right before you take your medicine. Those types of things. Okay, so that's kind of how you need to kind of start working through some of the questions that you're going to be given here and on the NCLEX. Okay, benztropine, we've talked about that with our anticholinergic meds. Don't give with increased heart rate, and then the trihexyphenidyl, or just more meds. Where did my mouse go? I lost my mouse. There it is. Got like 3 screens open right here. Okay, so information for benztropine, you're going to find this on page 219 as well, right? So it blocks the cholinergic receptors and inhibits the release of acetylcholine. So we're bringing down that level of acetylcholine. And it also has an action of blocking the dopamine reuptake. So remember, that is a way that our body kind of gets rid of these neurotransmitters so we don't have a whole lot going, right? They can reuptake it, they can destroy it by enzymes, stuff like that. So we're blocking the release of acetylcholine, and we're also blocking the dopamine reuptake. So we're trying to keep that a little bit more balanced. Side effects of all, same thing, dry mouth, blur vision, constipation. These can cause agitation, confusion, drowsiness, hallucinations as well. Contraindications with any anticholinergic is glaucoma, right? tardive dyskinesia. So we had, there was a good question about tardive dyskinesia versus like the slow tremor movements of Parkinson's with the last section. So tardive dyskinesia and the symptoms of Parkinsonism, even though they're both considered like tremors and involuntary movement, they're different. They kind of work in different ways. And so benztropine can actually make tardive dyskinesia worse with the myasthenia gravis. Also don't want to give it to kids. Other anticholinergics are part of the drug interactions, right? So here's with the dry mouth, the frequent sips of fluids, ice chips, hard candy. I didn't put it on here, but go into the bathroom before you take the medicine to help so you're not having as much urine in there that's retentioning, if that's even a word. And then always assess for wearing off effects. Okay. And then if you do have wearing off effects that they're complaining about, definitely let the doctor know.
Hey, Corby.
Okay. Yeah.
Just a question before you move on. So, just with like this past unit, I've kind of noticed that like when the meds are kind of in what's on that slide in like more of a table format, those meds are more mentioned more often on the test. So would you say that with the drugs that are like actually in table format and you kind of have more information that we're going to be more heavily tested on those?
Yes.
Than other ones?
Yes. Yeah. So you'll see, I don't do them with all the meds. I mostly do them with prototype drugs because some of the other meds on these lists are like under that classification per se. So I do this most with prototype drugs, but yeah, you're more than likely going to see it like benztropine on the test. I did one with, I know prednisone is big when we talk about prednisone in different sections and stuff like that. Now, for those who like these charts, kind of like this, you can do them. Now, like I said, I don't do them with all these meds, but you can definitely take these meds and, make a chart up with that yourself, which would help because you're seeing it, you're writing it. It might help you remember as well.
Okay, so, thank you.
Yeah. Okay, so dopamine replacements. So these are also called dopaminergics. They stimulate the dopamine receptors. And under this is carbidopa, levodopa. If there's any drug that is the best for treating Parkinson's disease, it is this one. This one is, bar none, the best medication to treat Parkinsonism. There's a problem with it, though, is that we as humans start developing a tolerance to it, and it is the best, but we kind of leave it as like last resort as well, if that makes sense. And so that's how you kind of want to look at this drug. It's the best drug, but it's also the last ditch effort. There's other drugs that work, that help, like the benztropine, that can extend the time from when you need the carbidopa, levodopa. I hope that makes sense. So they used to just produce levodopa. And what levodopa is you take the levodopa, it goes through, it crosses the blood-brain barrier, and once it gets into your brain and into that basal ganglia, what happens is your body changes it over into dopamine. So we're like, great, this is awesome. We've got this med that crosses, because dopamine, sorry, let me just preface this. I should have prefaced it with dopamine does not cross the blood-brain barrier. We can't just give somebody dopamine and have it help Parkinson's because it doesn't cross the blood-brain barrier. So we need something, and levodopa does. And we change levodopa into dopamine in the brain, which is great. The problem is we have enzymes in our body outside of the brain that breaks down this levodopa rather quickly. So only 1% of the levodopa that's taken actually crosses the blood-brain barrier and is able to be changed into dopamine. So people used to take a whole ton of this levodopa to try to get enough to cross the blood-brain barrier to alleviate these symptoms and to help. And what happens when you take a whole lot of medication? Well, you get a whole lot of side effects. So not only were they taking a whole lot of this medication, they were getting a whole lot of side effects, which aren't always pleasant. And so the US actually just said, forget it, you can't have levodopa. This is getting too dangerous. So what was developed was this carbidopa. So carbidopa is a medication that inhibits the breakdown of the levodopa outside of our brain. So it happens by an enzyme called dopa decarbolase, and this carbidopa goes and inhibits this COPA decarbolase enzyme to break down the levodopa. So that leaves more levodopa in our system, right? We can take less, it leaves more, it can cross our blood-brain barrier and be turned into dopamine, and all is well. And it was, I mean, it's great. That's why this is such a great medication. Carbidopa on itself, by itself, has no therapeutic effects on its own. Studies have shown it doesn't do anything without the levodopa with it. So carbidopa, levodopa is a combination drug together that pretty much are ineffective alone. Okay. So it improves the voluntary movement function by increasing the dopamine concentration. So this was fantastic. A fantastic development. Okay. So it does. Sorry, Stephanie, go ahead.
So on this slide, you have dopamine replacements as dopaminergics. A couple slides back, you had dopamine agonists and dopamine replacements as two separate classifications. So are they the same classification or are they separate?
They are separate. So dopaminergics are also dopamine replacements. Let's see. How do I have it on that other one?
You have.
Yeah, dopamine replacements are also called dopaminergics.
But if you go one line down.
Oh, yeah.
So which way is it?
Okay, this slide is correct. I'll fix that for you.
Sorry, just one more time. So
no,
dopamine replacements are not dopaminergics.
Right. In your book, the dopamine agonists are also called dopaminergics.
Okay.
So cross that out for those who have printed that. For those who haven't, I will change that and fix it on Canvas. Okay. So dopamine replacements. Yeah. Thanks, Stephanie, for that. I apologize for the typo on there. Okay, so carbidopa, levodopa replaces the dopamine, right? We're giving more levodopa to be changed into dopamine. And so we're just replacing the stuff that our body just isn't it's not making very well. Okay, so here's our carbidopa, levodopa. let's see, anti-Parkinsonism, dopamine replacement, and we talked about how it's transported, how it works in the body. So side effects, nausea, vomiting. One thing with this drug is that it does cause nausea and vomiting. So you think, okay, we'll take it with food and it will help the nausea and vomiting, which it does. However, taking it with food, especially the high protein foods, decreases the absorption. So there's kind of this give and take that you kind of have to work with taking it with food versus not taking it with food. If a patient can tolerate not taking it with food, that's the best bet. If they have to take it with food, it needs to be a low protein type meal or something like that. Okay. Can also cause hypotension, nightmares, impulse control problems, mental disturbances, and then suicidal tendencies. There is this black box warning with agranulocytosis, and then the MNS. Oh, I just forgot what that stands for. I have it written down here. I don't think I do. My mind just went blank. Anyway, I should have wrote that down because I thought I was going to remember, and I totally forgot what it stands for. Anyway, I'll clarify that. So with abrupt discontinuation, so we don't want to stop this drug abruptly. Any drugs like that you don't want to stop abruptly, you're going to want to wear or suggest that they wear a medical bracelet with it. Okay, with this medication, the urine and sweat will be discolored. So bodily fluids will turn like a reddish brown color. So if they sweat, they're going to see it on their clothes. Their urine will be darker. Doesn't necessarily mean they're dehydrated. It just discolors it. So knowing that their bodily fluids are going to be discolored, one thing to think about is, does your patient wear contacts? If they wear contacts, they are not going to want to wear them anymore because it will stain the contacts. And then a sign of toxic levels is the eyelid twitching. So if you have patients coming in and their eyelids are twitching, you know they're on this med. Might want to address that. Okay, dopamine agonists, aka dopaminergics. Like I said, I will change that on the slides. I apologize for that. These stimulate dopamine receptors. So these are the kinds that go in and they're like, they stimulate it and they're like, make more dopamine, make more dopamine. They're not replacing it. They're just telling us to make more dopamine, okay? So we have amantadine, bromocriptine, and pramipexole. These are all, that was a mouthful, okay? So one thing to know with amantadine, it's actually an antiviral drug, and it was the first one used to treat influenza A. But they found that it decreased the signs and symptoms of early Parkinson's disease. So they started using it for that too. And it also helps with drug-induced Parkinsonism. So if you're finding that, your patient taking their antipsychotic drugs is starting to get these symptoms, you'll want to stop, or change or decrease the dose of whatever is causing those symptoms, and then you can add amantadine on top of it, which will help decrease those symptoms, okay? And the purpose of a lot of these medications is just this, to delay the necessity of carbidopa-levodopa, because that's kind of the last-ditch effort, and it's a really good drug, okay? So we've got the bromocriptine, which is used in early Parkinson's, or it can be used in combination with the levodopa or carbidopa-levodopa. Oh, that is, when you're saying that 12 times a slide, it it gets a little tongue twisty. So a lot of these medications can be used in combination too to help out. And then the pramipexole is the newest. It's called Mirapex for those who are brand name people. It can be used in combo with it, and it also has fewer side effects than older dopamine agents. You're going to see that a lot. The newer drugs that come out are going to have less side effects than the older drugs. That's just how it is. That's how we want it, right? We want to improve on the stuff that we have. And how do we improve it? Take away all the negatives. Take away some of the side effects. Okay, now we have our MAO-B inhibitors. Selegiline is pretty much the one we're going to talk about here. I think it's pretty much the only one your book talks about. So this one breaks down the enzyme. It inhibits that MAO-B enzyme that breaks down the dopamine. So if we have less things breaking down the dopamine, we have more dopamine, and which will help even out that dopamine acetylcholine balance. Okay, this is really good for newly diagnosed Parkinson's disease. It can delay the use of carbidopa-levodopa by a year. It also, and used in combination, it prolongs the action of levodopa. So it decreases the on and off fluctuations. So you have less fluctuations with that wearing off, right? It also allows lower doses of carbidopa-levodopa, so you can start lower with that, which is good. The problem with this is that foods high in tyramine can cause hypertensive crisis. So large doses of this selegiline can inhibit another enzyme called MAO-A. Okay, and that MAO-A is what helps our body metabolize tyramine. And there's tyramine in a whole lot of foods. Does anyone have any idea what type of foods tyramine can be in? Okay, perfect, Megan. Cheese, wine. Meat, it's gotta be, I cannot figure this mouse out. Gotta be like cured meats. So you're looking more like salami, pepperoni, the cured meats. Mark Rockstar, ooh, I don't know. But they are in alcoholic beverages. And I know Rockstar's not alcoholic, but yeah, Megan, you're right. Cured meats, beer, wines, stuff like that. We've got bananas. Mark, you know what? It could be. I don't know what they put in those rock stars or in those energy drinks. They're a little sketchy to me. They throw all sorts of stuff in there. So, especially caffeine. Soybeans, pickled foods, any type of like pickled beets or ooh, are you talking about rock stars, Megan? Oh, that makes me so sick. That's nasty. Another good reason not to drink them. Wow. Good job, Mark. Good job. There's other ways to stay awake. I would highly recommend not drinking any of those energy drinks. Okay. So we talked about bananas, aged cheese, alcoholic beverages, including red wine, cured meats, soybeans, pickled foods, and sauces like soy sauce, shrimp sauce, fish sauce, and teriyaki sauce. I'm a teriyaki sauce fan. So all those things have tyramine. So gotta be careful with your doses of selegiline because it can inhibit the MAO-As, which help us metabolize this. If not, we're going to get into a hypertensive crisis, which is bad. So you can stroke out in a hypertensive crisis and potentially die. Nobody wants that. Okay. Now we have our COMT inhibitors. Okay, our catechol-O methyltransferase inhibitors. Entacapone is the one on your list. There is also another one called there's entacapone. Good grief. Talcapone. So there's entacapone and talcapone. Entacapone is the prototype, and that's the one on your list. So there's a couple drugs, but we're going to focus on entacapone. So this also is an enzyme inhibitor that inactivates dopamine. I think this one breaks this, the MAOB breaks down the dopamine, and then this COMT in the enzyme inactivates it. Does that make sense? It's kind of the difference there. You can kind of see a difference. So the COMT inhibitors increase the levodopa concentrations. They increase the dopamine concentrations. Can be given in combination in advanced Parkinson's disease. And this also lessens the wearing off effects from the carbidopa levodopa that can happen. So you don't get them quite so often or quite so severe before the next dose is done. Okay, so with it being an incurable and progressive disease that's going to need a lot of change in treatment, what is our ultimate goal of therapy, right? We know already that even with the medications, our patient's going to get worse. So what are our ultimate goals? Well, our ultimate goal in treating this disease with medications is to just have the patient have the highest mobility level possible. Okay, I mean, if you give them correct information and they, know about the medication, they know it's just progressive. It's going to get worse and worse, but we can delay that. And so we always want them to have the highest mobility level possible, right? We want them to have an improvement in as much improvement in symptoms as we can. Okay, obviously because their gait is changing, they're having the shuffle gait. And they have the bradykinesia. So when they trip and fall, they can't just like, ooh, go out and catch themselves, right? We trip and fall and we put our arms out and we, do this like really fast movement stuff. They don't have that. They're really slow. They're slow moving. So when they fall, they're like, they're trying to catch themselves and they just can't move as fast. So we want them free from injury, right? A lot of these medications can have, side effects. So we want them to be able to void and have normal bowel patterns, and then have the patient family understand drug therapy. This is just teaching again and understanding. With these medications, it can take weeks to see symptoms improve. Okay, so that's really, really important to tell the family with these medications is that it's like, yes, it will work, but it's not overnight. It's going to take a few weeks, maybe a month or two to be able to get the full effect and to see these improvements. Dosage adjustments would be expected, kind of like we've talked about this whole time. The dosages they're going to change, meds are going to change, combinations are going to change. Just with the progression of the disease. And then understand, and this is not just with Parkinson drugs or anything like that, it's all across the board, that some signs and symptoms that meds are meant to manage are the same signs and symptoms that manifest as adverse effects of the same medication. Does that make sense? So, for example, just throwing it out just as to help you understand, like a medication that is given to control, let's just say urinary retention, right? They're given a medication to help with urinary retention. One of the adverse effects could be it causes urinary retention to be worse. Okay, I know it's kind of hard to wrap your head around. You're like, what? Why would that even happen? Good question. But there are a lot of meds, not just with this group, but with more that we're going to see in other on other units that do that. The meds, especially in the heart meds, if they're given to treat dysrhythmias, they can cause dysrhythmias. So just know that a lot of things that they're meant to treat can be their side effects as well. Okay. Okay. Did that help explain things? Hopefully it does. Kind of went through all the classifications and explained how it all worked again. So those visual people. Okay, good.
Hey, Corby.
All right. Yeah.
So, like, that video was really interesting, but, like, how many medications does a person with Parkinson's end up on then?
That's a good question. I honestly don't know.
Individualized?
Yeah, it's definitely individualized. It really depends on how severe the disease is in that patient. And then it also depends on their compliance and if they can tolerate the side effects. So I could see somebody being on maybe as many as 3 different kinds, and then sometimes they're just on one, and you always get those people who don't want to take anything. So it really just depends on the doctor, the patient, and their compliance and how they can tolerate it.
Awesome. Thank you.
Yeah. Okay, so some things to know. We can either just kind of go through them, or we can answer them, or we can skip them, and you can go through these later. And it depends on what you guys want to do. So the pathophysiology, so the cause of Parkinson's. What's the cause? If it's pseudoparkinsonism, maybe we can figure that out, right? Maybe we can figure out, like, is it a certain antipsychotic you're using, stuff like that. Were you poisoned? Is it part of this disease process that you're having to another disorder? But as far as idiopathic Parkinsonism, you guys are right. It is a low dopamine, but the actual cause of it is totally unknown. We don't know. It just happens to people, and we don't know. But yes, the dopamine and having an imbalance of dopamine is absolutely right. We talked about the signs and symptoms. And then that video was really good in explaining why not just give dopamine, right? Dopamine doesn't cross the blood-brain barrier, first of all, right? And so any dopamine in our peripherals is not going to go up into our brain. And so we have to either get the levodopa up there to be converted, or use any of those other types of drugs to help with the dopamine. And then clinical manifestations, that kind of goes with the signs and symptoms, right? Okay, so which of the following assessment findings could the nurse see in a patient with Parkinson's disease? And we're going to select all that apply. And it looks like I've got 1, 2, 3, 4 slides of questions. Like I said, we can kind of go over them quickly if you want. You guys can look at those. So let's just kind of go through them. An abrupt onset of symptoms. So that isn't one because it has a slow onset. Okay, it's a slow progressive disease. Muscle rigidity, definitely going to see that. Involuntary tremors with the pill rolling especially, right? Arm shaking at rest, stuff like that. The bradykinesia, the slow movements. Now this one's interesting. Bilateral muscle weakness. Parkinson's does not affect the muscles, so you're not going to get any muscle weakness. Now it is going to change your posture and the way you walk, and so some people might link that to weakness, like as if you think if they fall, and if you were, hopefully not, but maybe hopefully it never happens, but if you were to see somebody with Parkinson's trip and fall, it might look kind of like a weakness, like they can't catch themselves. They're, it's not a muscle weakness though. It's the bradykinesia. It's the slow movements where they can't get their peripherals where they need to be at the time they need to be there. Okay, and then the shuffle gait and the posture, that has nothing to do with the muscle strength. It's the tremors, the bradykinesia, and the rigidity. I hope that makes sense. Okay, so what drug class does carbidopa-levodopa belong to? Wish I could find my mouse. There it is. Right, it's a dopaminergic. No, it's not. We decided it's a dopamine replacement. Gonna drop some dopamine. Okay, would there ever be a situation in which carbidopa-levodopa could not be used for Parkinson's disease? So these are the contraindications, right? There's absolutely situations where patients might not be able to take carbidopa-levodopa. Megan, perfect. Glaucoma. Glaucoma is a good one, right? Glaucoma, malignant melanoma, any type of like weird skin mold that they might think is some kind of melanoma. Don't want to take them with that. Antipsychotic meds, right? That's not going to work too well. Let's see, MAOIs. Renal failure, that's a good question. A lot of medications you have to be really careful with renal problems and liver problems, right? That's where a lot of the drugs are metabolized through. And so, yes, absolutely, you got to be careful with those. However, in your book on this particular medication, it does not mention either one of those. But on a lot, oh wait, just kidding. Renal hepatic disease, it's right there. So yeah, you got to be careful with those, renal hepatic disease. Orthostatic hypotension, right, severe cardiac disease, right. So there are reasons why people can't take carbidopa-levodopa, right? So are there other pharmacotherapy options? Well, yeah, we talked about like 4 other different classifications of drugs, right? Maybe it was 3. So there are other classifications of drugs that will help. Will it work as well as carbidopa-levodopa? Probably not, but is it treatment? Yeah. So we talked about what levodopa does, right? It crosses the blood-brain barrier, and then we changed that into dopamine. And then we talked about why it can't be used alone, right? I mean, it's got such severe side, you have to take it in such a high dose, and you get a lot of side effects that they can be dangerous. So you don't want to use it alone. In fact, it's banned from the US to be used alone. So carbidopa and levodopa together are great. Just levodopa, they don't sell it here in the US. You can't just get that. Okay, what carbidopa does, talked about that, right? It inhibits that decarbylase enzyme from breaking down the levodopa. And I don't exactly know the actual like why, but studies have shown that it is not effective if used just alone. It doesn't do anything. It only works when given with levodopa. Okay. And then what are the therapeutic outcomes we're hoping for? So, right, the biggest one is just to give that patient the best quality of life. Be able to perform the ADLs, be able to be independent, stuff like that. Okay, can it be abruptly discontinued? Nope. Can cause problems and make your symptoms more severe. Is nutrition a factor in carbidopa efficacy? Perfect, guys. Protein, absolutely. Yep, you got to be careful with taking it with food alone will decrease the absorption, but high protein really affects it. So if they do have to take it with food, they can't, you want to tell them not to take it with high protein foods. So Megan, to answer your question, it is one pill. They put them together in one pill. And then we talked about the weaning off effect and how can a nurse tell it's occurring. Probably the biggest way to know is just by the patient telling you. Depending on when the patient's appointment is, or maybe if they're in the hospital, when you're taking care of them for a 12-hour period and you start seeing their tremors, maybe you can tell if it's like a clinic or like a home health care visit or something. You might not be able to tell because maybe they just took their pill, not too long ago. So sometimes if you're with the patient a lot for a long time, you can probably see it happening. But if it's like a short visit or a doctor appointment or something, the best way to tell is just the patient or the caregiver telling you. And then you go and tell the doctor, right? Let him know. Patients sometimes forget to tell you, they'll tell you things and then the doctor will come in and they'll be like, oh, well, I already told somebody. And then sometimes they don't tell the doctor things, or vice versa. Okay, after this video, we'll take a break. This is a really good video. About Michael J. Fox. What do you guys think of that? I really enjoy watching that because it's absolutely inspirational, right? And you can see, like, you can see all the symptoms he has. He's got that flat affect type thing, and the tremors and kind of shuffle gait, stuff like that. So anyway, kind of cool. Sorry. Okay, so one thing, if you guys have, like, I think it's 10 or 12 minutes long. TED Talks aren't very long. But if you have a hot minute, you can either look it up on TED Talk or you can click this link and watch it on YouTube. And it's called What Parkinson's Taught Me. And it's a British lady who got diagnosed at 29, I think. And anyway, she kind of, she's pretty dang inspirational too. And she kind of goes through her experiences and just what Parkinson's has taught her. So just if you have a hot minute, I would, I think it was really good. You can take a look at that, and that's more of like an inspirational thing, not necessarily a teaching thing. But okay, we've got Alzheimer's next. It's not very long, but let's take a break. Do you want to go to noon and kind of do a longer break? Kind of a lunchish break? Or do you just want to do 10 minutes? How are you guys feeling? Lunch? Okay. Okay, we're good. I apologize. Like, time gets away from me and I'm like, oh my gosh, it's 11:30. We haven't even taken a break. So I apologize for that. But let's go to like 10 after. Should we do 12:15? Meet up. 12:15. Let's do that. So it's on slide 14. When we talked about carbidopa levodopa. And I didn't mention, it's here, but I didn't mention it. One of the off-label uses, not just for this med, but other Parkinson meds like benchtropine or like the Mirapex, stuff like that. One of the off-label uses for those meds is restless leg syndrome. So, I don't know, just something good to know about these meds, that they're good for restless leg syndrome. Okay. 24. Okay. So also covered in this chapter is Alzheimer's disease, and it's a super crazy short section, and it really only covers 4 drugs. And I don't even know if all 4 of them are on your thing. I think only a couple of them are. One, two, three. I think only just a couple of them are covered on your drugs to know, and there aren't very many drugs for Alzheimer's. Okay, so quick pathophysiology of Alzheimer's. So this is also pretty much kind of a rule out disease as well. It's a type of dementia. It's incurable. Also, kind of with Parkinson's, we don't know exactly why or how it starts, how people get it. And they can test for markers to see if you have different genetic markers for Alzheimer's, but to actually like be definitively diagnosed, it really just takes an autopsy to look at the brain. But there are things that we do know and we can see to make it a more definitive diagnosis. So, cure is unknown. So we measure Alzheimer's in 3 stages. There's a mild, a moderate, and a severe. Mild is considered the early stage, severe is the late stage. And we'll kind of talk about those in detail here in a minute. So cognitive deficits are associated with a couple different things. So there's a degeneration of cholinergic neurons in the brain. Okay, there's a decreased production of acetylcholine. So where Parkinson's was the dopamine, Alzheimer's is the acetylcholine. We get some neuritic plaques that form in the brain, and then this neurofibrillary tangles and twists inside these neurons. So it's not just a decreased production of acetylcholine, that's part of it, but this disease actually changes the physical neurons. It's a physical change with these tangles and the twists and the plaques that form. So the stages of Alzheimer's, here we have the mild, moderate, and severe. So here are things that people can do in each stages. So you kind of understand if your patient has mild Alzheimer's, you can kind of put that together, right? So in the mild, it's the early stage. You have some memory lapses, a little bit of difficulty concentrating. They misplace objects and kind of forget where they put them, forget what's just read. So maybe they're having to read things over again. Problems planning and organizing things. I feel like I have all of these right now. So who knows? Maybe I have early Alzheimer's. But these are the types of things. They can still drive. They can still socially interact. They can still carry on conversations and know, what they're saying and remember things. And they can still work. They can still function. Sometimes in these early stages, even caregivers don't really see kind of what's going on. If anyone has seen This Is Us, anyone a fan of This Is Us? I'm sure you're all raising your hands. But she's kind of going through the mom of the family is, can you guys all hear me? Okay, Chelsea, good. Somebody answered. You're all hearing me. Okay, good. So the mom, for those who have seen the show, who are watching it, the mom is going through kind of this early stage of Alzheimer's, right? She's having these memory lapses, kind of misplacing her phone, can't seem to find it, just kind of having these mild problems that her and her husband are just writing off. They're just oh, it's not a big deal. And the family who's not with her all the time is the ones that are putting it, seeing the red flags, and they're wait a second, something's different. And the caregiver or her husband really isn't seeing this, and they're how do you not see this as it progresses? How could you not see that this is a problem? Because it progresses slowly. And so some people might be oh, I'm getting old, I'm starting to forget things. Not necessarily due to old age, but they're still functional. They can still take care of themselves. They can still, go to work, stuff like that. Now we're going to get into the moderate stage. This is the longest stage. This is when you start seeing behavioral changes. And some of these changes can be due to increasing symptoms of these, if they keep misplacing their phone and every time they turn around, they're where's my phone? I mean, you can only imagine that they'd get frustrated, right? Or if somebody, is questioning them all the time, not only is that going to cause behavioral changes, but in Alzheimer's in general, you get behavioral changes. So some of these changes you might see just with frustration in progression of this stuff. Okay. But then you do get some personality changes, stuff like that. You'll start seeing change in sleeping patterns. Maybe they're not sleeping as much, or maybe they, are up all night now where they didn't before, just changes in that. They start having a problem recalling personal information. They can't remember where they live. They can't remember maybe, where they bank, or, maybe phone numbers that they knew, or their birth dates. They're having a hard time remembering stuff like that. They wander and become lost because they can't remember where they live. They can't remember where they are. And then they start having difficulty controlling their bowel and bladder. They might start having accidents. And then in the severe is what you would expect. It's severe. That's when they start forgetting experiences. They start forgetting people. So, if you have friends or family or anything like that who maybe has a loved one that has Alzheimer's, and they get upset because they go and, this lady can't remember her own daughter. It can be really hard on people. This is a really hard disease. High levels of assistance are needed. These are the kind of people that are going to be in assisted, not even assisted living. They're going to be in like nursing homes. They lose the ability to walk, to sit, to swallow, and are very vulnerable to infections. So that's kind of how those stages work. Here is a visual of a healthy brain and then a severe Alzheimer's brain. So it's a physical change in the brain as well as dealing with the neurotransmitters. Let's learn a little bit more about Alzheimer's. Okay. So I think that was a good visual on how it all kind of works together. So the drugs managed for Alzheimer's disease, there's very few of them that are approved. And like he said, they have side effects and can even increase mortality. So that could be a problem. Well, the ones that are approved that are acetylcholinesterase inhibitors, like he talked about, right? That's the enzyme that's breaking down the acetylcholine. So it's inhibiting that enzyme. We've got the rivastigmine, donepezil, and then the glutamine. Or glutamine, however you want to say it. And then we've got this momentine. Takes me a minute. And that's the one that blocks the glutamate from allowing the ions from entering into the channel and exciting that too much, right? So that one is used to manage moderate to severe Alzheimer's, to help with memory and attention, reasoning and language skills, often used in conjunction with a cholinesterase inhibitor. And then, like we said, the side effects, confusion, dizziness, drowsiness. Confusion, like when you talk about memory and attention, that can be confusion, right? It can cause confusion. So drugs that are meant to treat things can actually cause that too. Okay, that happens. And then drowsiness and headache. So here is rivastigmine, which is the cholinesterase inhibitor. Right, it's given PO and transdermal. It improves memory loss in mild to moderate Alzheimer's. And it has been shown to actually slow the disease process. Okay, but here's the side effects. Liver toxicity, that's really big. So then in nurse education and responsibilities, we're going to watch those liver enzyme labs, right? The AST, ALTs, stuff like that. It can cause orthostatic hypotension, which is can cause problems, right? If you already have someone with low blood pressure or a slow heart rate, that can make it worse and make them more prone to accidents and syncope. There's bradycardia, seizures, and then severe life-threatening stuff. We've got heart failure, dysrhythmias, MIs. So contraindications, any of these things, right? Any people who already have this stuff. But especially liver disease. And then drug interactions, NSAIDs increase the GI effects, of course, so this can upset the stomach as well. And then tobacco increases the clearance of the drug. And so here we're going to take on an empty stomach, watch those liver enzymes, and then obviously observe for behavioral and cognitive changes. Is it working? Is it not working? These types of drugs, just like Parkinson's, they take a while to start working. So you're going to be looking, for a few weeks to a couple months to see if there's any improvement. So you want to observe for those behavioral and cognitive changes throughout treatment. So here is a little, it's very short. It's kind of funny because you can totally tell the doctor, if you even want to call him a doctor, he just responds really funny to the questions. But it's got some good information in it. Right? Okay, so you guys got the same kind of vibe I did. However, it does have some good information on there. It talks about how it doesn't work for everybody. Right? They made it sound like it was like really rare that it works for people. I think it's probably a little less rare than, or a little less rare than kind of what they make it out to be. What she said at the very end, so a lot of people do have problems with the side effects. So, you know, as goes with any medication. But then what she does say at the end is that if one medication isn't working, it's very rare that a different one will. So if one isn't working, none of them will. So that's also good to note. So some non-pharmacological therapy in that Khan Academy video, it did talk about behavioral modifications. It helps target agitation, the irritability, aggression, anxiety, and it helps the caregivers cope with those. This is with Parkinson's. This one is a really hard one to deal with. Parkinson's is more of a physical disease with the tremors and stuff like that. This can be as it progresses, but a lot of it at first is mental, and it's really hard. So, you know, a lot of education, help the caregivers, get them support. And then I don't know if any of you guys have heard like music. I imagine that she's probably listened to music. Music is like, there is a connection between music and Alzheimer's. It's really interesting because depending, like there have been studies that shown with people, like if you play music from their childhood or from growing up, like they kind of have these moments of like relapse where they're like, they can remember things, they're, you know, like it all comes back. It's like they're their old person, and then they jump back into the disease. So really interesting. But so really, I don't know if you can hear that like drilling sound. I have no control over that. Anyway, so behavioral modifications, support, and teaching for non-pharmacological stuff. So what do we know about the causes of Alzheimer's? Yeah, not very much. There's no cure. It's progressive. It affects the acetylcholine. And then it does cause those physical changes within the brain, right? With the neurofibrillary tingles and twists and the plaques. So what's considered optimal in the management of Alzheimer's? Well, it'd be to try to delay the process, right? If you can, delay the progress of the disease, and then keep the patient as functional as possible. And then what type of drug class is used in the management? The acetylcholinesterase inhibitor. And then we've got that one memantine that does the glutamate one, right? What requires close monitoring in those taking rivastigmine? Getting a little later, I'm having problems talking. Right, liver. Right, ALTs, ASTs, liver function. Yep. And how long does it take for these medications? Now, this just says one medication, like rivastigmine, but they're all lumped in. We all know that all these medications take a long time. And that's another teaching thing. You know, sometimes you gotta be careful with how long these meds take and educating your patient, because like you give them and say, hey, this is for your Parkinson's, it's gonna help with your stuff. You're gonna get a call in a week saying, this isn't helping. And so you need to be careful, you know, you need to watch out for, be careful with what you're telling them and what's important, because, you know, if you told them, hey, it's going to work, but it's going to take a while, you got to be patient, you're not going to get that call in a week, right? They're already going to know. Can drugs for Alzheimer's be used concurrently? Yes and no. So if we go back, right, these drugs all do the same thing. They're acetylcholinesterase inhibitors. They all do the same thing. So taking more than one of these drugs isn't going to help. More is not always better. But this drug works a little differently, right? It blocks that glutamate. And so it is often used in conjunction with the cholinesterase inhibitors. Okay, so these guys can't be used in conjunction with each other, but one of these and this guy can. Okay, that was kind of a somewhat loaded question. And then what does behavioral modification help in those with that should say AD, not PD. Talking about Alzheimer's. That's weird because in mine it has AD. This one still says PD, which I don't know how that happened because it's the same thing. I got off the same file. Anyway, behavioral modification helps with the agitation, frustration, anger, right? The behavioral stuff. Okay, that is it for Alzheimer's. So like I said, it's a really short section. Okay. You guys need to stand up and stretch those bellies. Let me upload another file here. Sorry, I wish we could like have them all uploaded all at the same time. It does just take a hot second. Does anyone have any questions about Parkinson's or Alzheimer's or their drugs? As we quickly go through anti-seizures. Okay, well, if you end up coming up with some, let me know. Okay, so Parkinson's and Alzheimer's is chapter 20. We're going to go take a step back in the book and go to chapter 19. And we're going to talk about anti-seizure medications. Okay. Here's your learning objectives. Fantastic. Okay, so epilepsy. Sorry, let's try that again. Epilepsy is a seizure disorder. It's from the abnormal electric discharges from the cerebral neurons. So it's just like an excitatory type deal with the brain. Characteristics, you can sometimes have loss of consciousness and then involuntary and controlled movements. Those are some of the characteristics. There are a lot of different types of seizures. So like there's absent seizures where they don't lose consciousness and they don't have involuntary or uncontrolled movement. But as a general, this is kind of what happens with most seizures. The cause, it kind of depends on the type of seizure. So a lot of them are unknown, okay? We don't know exactly why you have epilepsy, you just do. There's others that can be secondary due to brain trauma or anoxia, loss of oxygen in the brain, infection, strokes, and then there's isolated seizures, which are due to fever, electrolyte imbalances, acid-base imbalance, alcohol, or some drugs can cause seizures too. So a couple different reasons. This one, unknown, is usually called idiopathic. So here's your idiopathic with unknown cause. We can't really pinpoint a reason why you're having seizures, right? We don't know. Secondary, we talked about that with the brain trauma, brain anoxia. These are not associated with epilepsy. It does cause seizures, but not considered epilepsy type seizures. That's where you get your febrile seizures, Hypoglycemic reactions can cause that. And then electrolyte imbalance, metabolic, drug, alcohol. With this type of seizures, when these are corrected, when you no longer have a fever, when you get your blood sugar in balance, when everything is a-okay again, the seizures cease and they won't reoccur. Okay, reoccurrent seizures are usually from birth or perinatal injuries, head trauma, cognital malformations, and tumors. So those can cause recurrent seizures. Okay, so international classification of seizures. Now your book has a whole table of category of, let's see, 3, 6, 9, 12, 15, 22 different types of seizures. You don't need to know the different types of seizures, okay? And I don't even think you need to know what drugs treat what seizures, but know that these are kind of the most common ones, right? We have our tonic-clonic, which used to be called grand mal. They're the most chronic, alternating muscle spasms and jerkiness. We have our absence or petit mal, brief loss of consciousness, or sometimes not even loss of consciousness. Usually occurs in children. And then you got your psychomotor, which are complex, have a bunch of complex symptoms, and then repetitive behavior like tics or something like that they can get. Okay, so just a review on that. So action of anti-seizure drugs. What do they, how do they work? What do they do? They're also called, I told you a lot of these have a lot of different verbiages. So anti-seizure drugs are also called anticonvulsants or anti-epileptics. Okay. They stabilize the nerve cell membranes. They help suppress that excitatory, that electrical impulse in your brain that's making everything excited. Okay. So we have a couple different mechanism of actions. We have some that suppress the sodium influx. It inactivates the channel and prevents the firing. Okay, here's the drugs that go with that. We're gonna visit these again. Here's some that suppress calcium influx, right? We talked about the sodium influx, now we're talking about calcium influx. Some of them do both. These are the ones under that category though. Enhance the action of GABA and then promotes GABA. So we have gabapentin, that's kind of easy to remember, right? Gabapentin will promote GABA release. And then we have the barbiturates, benzodiazepines, classification of drugs that enhance the action of GABA, okay? If you have more GABA, you're gonna be more, your brain's gonna be more relaxed. We are gonna visit GABA in other units as well.
Corby, you're still muted.
Thanks. So that video had a lot of information in it, and a lot of it was more detailed than you need to know. What I really want you to know is just like, I mean, just with the mechanism of actions, know how the sodium works, and you're blocking the sodium, the calcium, you're blocking the calcium, right? And then the GABA. He talked about a whole lot of meds that aren't on your list, and I don't even know if some of them are in your book. So as far as the meds, follow what is in your book and on your list, okay? And then like the alpha-2 delta receptors, like just whatever's in your book. I just wanted you to kind of, he goes through and explains it really well, but he does a lot. So anyway, take this for what it's worth and make sure, you know, you're studying what's in your book. I hope that makes sense. So you don't necessarily, like, he goes into a lot more information than you actually need. Okay, so anti-seizure drugs, how are they given? And, you know, how do we start them? Stuff like that. So they're started one at a time. You're not going to see somebody who has a seizure and they're going to add, you know, give them 3 meds at the same time. So to help control, they're monitored one at a time. If one of the medications doesn't work, it might be increased, or they might be like, yeah, maybe it's not the sodium channel blocker that we need. Maybe we need a calcium, or maybe we need a GABA. So not all of them work for each patient. Not all of them work for the different seizures either. Okay. In the end, though, often more than one drug is needed. Okay, so we're going to start with one drug, but maybe, you know, once we get it controlled and, you know, now we're looking at, okay, these seizures are being controlled a lot better, we're probably going to see more than one medication on that. Does that make sense? We have first-line drugs, second-line drugs, and then, like I said before, they don't always work on certain seizures. So the choice of drug depends on what type of seizures there are. Okay, so here we go with hydantoins. And here is the phenytoin. So the ending of the word matches. That helps. A lot of these meds, especially this one, is contraindicated in pregnancy. It's a teratogenic. Bad news. You don't want to be taking it with meds. This one I kept the therapeutic serum level. On the other ones I took them off. But do know that it has a narrow therapeutic window. And I think that's mentioned on the next slide. But here's some of the side effects. The gingival hyperplasia, that's the overgrowth of the gingiva. Nystagmus, headache, dizziness, slurred speech. Purple glove syndrome, that's kind of interesting. It's like a swelling and discoloration of your hands that you can actually lose your hands from. Like they'll have to amputate it. I believe it's pretty rare, but I thought it was kind of interesting. Ventricular fibrillation, depression, and suicidal ideations. These are highly protein bound, so you want to be careful with those in low serum protein level patients. Okay, so here are some drug interactions. There are some drugs that increase the effects of phenytoin. There's drugs that decrease the effects of phenytoin, and then there's drugs that phenytoin decreases the effects of. Does that make sense? So I know there's a lot here. This folic acid is important. A lot of these meds mess with the folic acid. So just so you know, antacids, want to be careful with when we get to the GI unit. Antacids affects a lot of drugs, surprisingly. Here's your ginkgo, right? Talked about ginkgo today. Oral contraceptives, be careful, it decreases the effects of oral contraceptives. Anticoagulants, antihistamines, stuff like that. So here is this. This is kind of a big slide. It's got a lot of information on it. Let's see, what didn't we cover? Talked about the hyponatremia. A lot of this has the information we've just talked about. Assess renal and liver function, right? You always want to do that. Monitor your glucose. You want to shake suspensions before use. It says do not drive. It does, some of these do cause drowsiness and dizziness. So for the first few doses that this patient's taking, they need to be careful not to drive with them. Once they know how it affects them, they should be able to, decide if it's safe to drive. Teratogenic, don't use with alcohol or other CNS depressants. This isn't a medication you want to just take away as well. So you want to be careful with that. Let's see. Okay. So next we have our barbiturates. Here we have phenobarbital. This enhances the GABA activity. It's used for the clonic tonic partial status ellipticus. That is an emergent situation. Status ellipticus is an emergent situation. Side effects are sedation and tolerance. This is scheduled for medication. You can develop a dependency and tolerance to it. So, and then discontinuation should be gradual. Oh, here's this class 3. This picture says class 4. They probably upped it. Let's see. It causes sleepiness in children. It can cause problems with behavioral or learning. Have behavioral learning issues. You see a lot of kids on phenobarbital. At least I do. Well, I mean the ones that have issues that come in. So this has a less pronounced teratogen effect, so it's a little safer than phenytoin. Still, if you can avoid it though, that would be the best. It is safe to use in infants and children. It's used worldwide and it's pretty cheap. Some of these can be kind of expensive. So here's your tolerance and dependence. Sudden discontinuation with a lot of these meds can result in recurrence and seizures, and they can throw them into a status ellipticus type situation. Succinimides. Here we have ethosuximide. Okay, this is one of your calcium influx drugs. Used for absence seizures. I swear on mine. I thought I took all the therapeutic ranges off. You don't need to know the therapeutic ranges. They just all usually have a narrow therapeutic window. So you're definitely going to want to watch your levels with a lot of these meds. If the dose of the medication is less than the therapeutic range, then you're not going to see any type of improvement. If it's more, then you're going to see toxic levels. So you want it right in the middle, kind of how we already talked about a couple weeks ago. There's your renal and liver impairment again. Then your benzodiazepines still. You've got your clonazepam, clorazepate, diazepams. These are mostly used, these two are usually used at home. You can see people on Klonopin and clorazepate. Now this diazepam, this isn't, and lorazepam, these aren't usually, like a doctor wouldn't prescribe these to, send home with a patient and say, okay, this is to treat your seizures. This is more of an emergent drug, both of these. You're going to see them in the ER to treat status ellipticus. You might see them on the floor if they're having recurrent seizures for some reason. You'll see these ordered. These aren't like a stabilizing med, really, that are a long-term med that you're going to see them on. Does that make sense? Short-term emergent situations for diazepam and lorazepam. And then you have your immunostilbene. This is your carbamazepine. So this one's used in psychiatric disorders. Some of the gabapentin is as well, phenytoin. Sometimes you can see them used in anxiety disorders. They've seen that it helps with that a lot. So you've got your bipolar disorder, alcohol withdrawal, and then look, grapefruit. We talked about grapefruit. It's just bad news. So you can get a toxic interaction with grapefruit. And then you have your valproates. And this is your valproic acid, your Depakote. You get your dizziness, drowsiness, insomnia, weakness, suicidal ideation, thrombocytopenia. Your book doesn't go into a whole lot of detail on this. This is a pretty short chapter where like 3.5 pages is just a med table. So definitely know your classifications, but then, check out your individual drugs on there. Let's see. This is one of the first line anti-seizure drugs. Okay. This is your valproic acid, the first line, most popular and where they're going to start it. Okay. This is the sodium channel. It also has effects on GABA and calcium channels. So like I said, some of them do different things. Your book splits them up into each section, and pretty much on the slides that I have up here, where was it? Here we go. Slide 7. See how I have these? These are the drugs that your book lists under these actions. So what's going to happen is these may affect, like these are sodium influx ones. They may affect the calcium too, but learn them how your book has them under. Does that make sense? I tried to kind of give you that right there. Okay. So off-label uses for these: bipolar disorders, migraine headaches, too, and that I have that bottom part cut off. Oh yeah. So it can prolong your bleeding time, cause liver damage. A lot of drugs causes liver damage, pancreatitis. And gabapentin's a good one. So you can remember GABA, right? Gabapentin. Let's see. This is also used for restless leg syndrome. Neuropathic pain. A lot of like diabetics with their peripheral nerve pain will be put on gabapentin. Sometimes it talks about shingles, fibromyalgia. If you have any like back nerve problems, this is it's really good for that too. Okay. So any type of nerve pain, it works really well with, and seizures. Here's just other ones that I just want you to be able to be like, oh yeah, I've seen that med. Okay, so anti-seizure drugs given given IV for an emergency. The biggest one you're going to see is lorazepam. You're going to see some diazepam maybe, but lorazepam, it has a really short half-life. Given, like we said, in emergent situations, it's the first line drug that you're going to do. It works really fast and really well to stop those status epileptic seizures. Okay, we talked about how they're a medical emergency. You need to take them to the ER. So status epilepticus is basically a seizure that won't stop. Like it's just a continual seizure that does not stop. That's why it's a medical emergency. Treatment, you're going to get the diazepam and lorazepam, and then they're going to put you on some kind of med that's going to help you stabilize. Okay. Now, lorazepam, diazepam, they're controlled substances. They're CNS depressants, right? So we're going to get the low respiratory rate. So you need to be careful and watch for that. And then we talked about pregnancy. So a lot of them are teratogenic, right? Can't take them in a pregnancy. Couple reasons. They inhibit the vitamin K. So infants have been, you can get a hemorrhaging infant. And then my screen just went out. There it goes. And then it can affect the folic acid, like we talked. So there are some drugs that are safer than others, but they should, all pregnant women should be on folic acid anyway. And then especially anti-seizure drugs, they should be on more folic acid. Okay, and then magnesium. So magnesium is an anti-seizure drug, which is usually given in pregnant women. They are to prevent seizures in the preeclamptic, preeclampsia patients. It's not used to bring down the blood pressure, because preeclampsia, right, that you get the high blood pressure. Magnesium isn't meant to bring down the blood pressure, even though that can happen. It can help bring down the blood pressure. It's not the blood pressure that's going to cause the seizures. What the magnesium is actually given for is to prevent seizures in these preeclampsia patients. Does that make sense? Let me try to say it again. So magnesium sulfate in these preeclampsia, eclampsia pregnant women is not given for blood pressure. Okay, that can be one of the side effects. It can help bring down the blood pressure, but that's not why it's given. It's given to prevent seizures that this preeclampsia can cause. Okay, make sure you understand that. That may or may not be on the test. So just, a side note there. Okay, can cause CNS depression, respiratory depression, and then you get your flaccid muscle tone. Metallic taste doesn't necessarily make you feel right. Stephanie, I think it can probably be used both. Like if they're in a seizure, they'll probably throw magnesium on, but they give it to prevent seizures. So if you're ever in L&D, or maybe you're on postpartum with an antenatal patient, or even a postpartum patient that's had preeclampsia, you're going to see magnesium on top of them. No, they'll probably throw if they're actively in a seizure, they'll probably throw lorazepam on top of it and then throw on magnesium as well. But most of the time you'll see it. The patients that have had prenatal care, they can kind of, like there's warning signs, they check blood pressure, stuff like that. So a lot of these patients kind of know that they do, or they have a history. If they're like, oh, I had preeclampsia with my first baby, then they're going to take precautionary measures. Does that make sense? So magnesium is to help prevent the seizures. And then you'll see them probably be given, that magnesium will be given through their postpartum stay a little bit too. So, but I hope that made sense. If anyone has questions, let me know. Text me, call me, tell you need clarification, whatever it is. Okay, and then So here's with febrile seizures. Febrile seizures usually affect children between the ages of 3 months and 5 years. You're going to see parents come in. They're scary. Seizures can be scary, especially in kids, and especially if they haven't had them before. You're going to get parents that are just like freaking out. So they are scary. But you bring the fever down and the seizure stops, and it's usually not going to recur again. After they're about 5 years, you usually don't see febrile seizures once they're older than that. But there is a chance. There's a 2.5% chance of children that have febrile seizures can develop epilepsy. So a lot of sometimes you'll see kids having febrile seizures, and they'll admit them to the hospital overnight for observation, just to make sure we can keep the fever down. And for whatever reason, they don't start developing concurrent seizures that can be later diagnosed as epilepsy. Does that make sense? So there are some high-risk patients. Maybe there are some sensitive kids that are sensitive to high fevers, or that are known to have a lot of fevers with, have a lot of seizures with fevers. Somebody should make a rap with seizures and fevers. Anyway, so they can put them on prophylactic treatment, but that's pretty rare. And people with these types of kids with febrile seizures, don't be surprised if you see some diazepam ordered for them if they happen to have another seizure. Most often they don't, though. Okay, so patient education. So they can cause confusion and dizziness and drowsiness, headaches, depression, nervousness, all that good stuff, right? And then you add on top of another CNS depressant, right? You can cause more problems. It's really important to keep up your follow-up appointments and all your labs. Remember, they have a narrow therapeutic window. So if you're getting labs drawn, or if your patient's getting labs drawn to test your levels of these drugs, it's really important for them to keep up those appointments because of the narrow therapeutic window. You don't want to get it toxic, but you don't want to have it not effective either, right? And then these types of drugs, if it's used as like a long-term stabilizing type drug, then they don't want to suddenly stop taking it. Also, sometimes kids or young people that have been diagnosed with seizures or epilepsy, if they have really good control on medications for 3 to 5 years, the doctors can try to start weaning them off, because sometimes they can grow out of their seizures, if that makes sense. Okay, so more teaching. They're going to want to take any missed dose as soon as possible, but don't take a double dose. Because of that narrow therapeutic window, you don't want to throw them over the toxic level. If they had a dose at 9 and it's 11, have them take it as soon as possible. But if it's like 4 in the afternoon and they have another dose due at 6, too bad you missed it. Does that make sense? Don't double dose. Wear a medical alert bracelet, and then always avoid that grapefruit. Just bad. And then off-label seizure treatments. There have been success with some patients with severe seizures that the medications, for whatever reason, won't work. If you put them on a keto diet, it tends to really help control those seizures. So I've seen a couple of kiddos come in and be hospitalized, and they're on a keto diet, and the parents claim that it works, and that's great. But there's kind of an off-label. So diet can definitely play a part in their controlling these symptoms and this disease with diet. Okay, so the rest are questions with answers. Do you guys want to go over them? Do you want to be done for the day? Do we have any? Do them? Okay. All right. Doesn't look like you have anyone contending with you, Stephanie. So I think we'll do them. Okay. So what's the highest priority nursing diagnosis for a patient taking phenytoin? So we have anxiety, risk for falls, risk for constipation, deficient fluid volume. Okay, so we know that some of these medications can be taken for anxiety, right? So that's not going to be it. Doesn't do anything GI related that we talked about or urinary related, right? So B, risk for falls. It's a CNS. These are considered CNS depressants. So, you know, you're going to get dizziness, drowsiness, right? So risk for falls, definitely. Okay. Before administering a daily dose of phenytoin, it is most important for the nurse to do what? So any ideas? Okay. You guys got it. I can't tell which one. This one is also B. So I can't tell which answers were for the last one and this one. But this one's B because it does have a narrow therapeutic window while in the hospital, and especially if this patient is newly diagnosed, you're definitely going to want to check phenytoin levels. Now, there's not a reason to maintain the patient on bed rest. Now, it does cause drowsiness and dizziness, right? But that doesn't mean they have to be on bed rest. You can just tell them like, hey, this might cause you to be a little drowsy or dizzy. Please call me if you want to get up, right? They can still get up. They don't have to be on bed rest though, okay? They just need someone to watch them as they get up, right? Or to help them so they don't fall. Okay, monitor intake and output. It doesn't affect the urinary system. We're not going to see like any urinary retention or anything like that. And then monitor renal function tests. That's not a huge priority right now. It's the narrow therapeutic window. Okay, so a patient was discharged 3 days ago on phenytoin for a seizure disorder, comes to the emergency department experiencing seizures. What will be most valuable to determine the etiology of return seizures? So do we want a CT scan, an EEG? Do we want phenytoin levels, or do we want to know what their electrolytes are? Okay. So a CT scan isn't going to really tell us anything. I'm sure they already had a CT scan when they first started having seizures, right? An EEG, that's with the heart, right? So he's not complaining about chest pain or palpitations or anything like that. So that really it's not doing anything. And then electrolytes, I'm not sure what electrolytes are going to tell us in this situation. So yes, serum phenytoin levels. Chances are if he was discharged on therapy, but now he's still experiencing seizures, chances are his dose is not high enough, right? He's not up to that therapeutic level yet. He's somewhere down here, a little low. So maybe we need to bump up his dose to get it in that therapeutic level. So your guess was right. For those who guessed. I'm sure there's some who knew. Okay, when assessing a patient taking hydantoin, I think I'm missing a P, or that's messed up. Anyway, which indicates an adverse reaction. This one might not be quite so. So we're talking about an adverse reaction versus a side effect. Okay, so this is a toin, right? A hydantoin. So we're probably talking about phenytoin. Okay. It causes not the atrophy of the gingival, right? It causes the overgrowth. So yeah, like I don't have a very good explanation for all of this. This would be like a no question. So yeah, it is thrombocytopenia. Okay, so we're experiencing status ellipticus, right? Which means, I don't know why the pictures didn't show up on here. It's just a blink thing. Anyway, I have little pictures on mine. They're just colorful. It's not, doesn't have anything to do with the question. It's just colorful sticks. Anyway, so we've got status ellipticus. It's an emergent situation, right? So you know that there's going to be an immediate administration of what drug? What drug is our emergent drug? Right, diazepam. So diazepam, lorazepam, those are going to be your emergent drugs, right? The phenobarb, the phenytoin, valproic acid, those meds you're going to see as more controller meds. But they will probably start one of these after giving that and getting the seizures under control. But for treatment of emergent status epilepticus, it's going to be diazepam or lorazepam. Okay. That's it. That is all I got. Do you guys have any questions? So for the learning activity, I have a little paper. Mark, I won't lie. I'm sitting there thinking, TY, what does TY mean? And then Megan put thank you. And I'm like, oh, okay. I think I know what TY means. Sorry. It's my brain. It's not firing quite right. Okay, so if anybody has any questions on anything, needs clarification on anything, please let me know. I really hope this time we're a little bit better overall with thanks, Chelsea. I'm not alone. Thank you. Hopefully this next test it'll get better once you guys figure out you know how to study, and then it's always the whole like learning to think like a nurse. I know I hated hearing that when I was in nursing school, but I hope I kind of tried to help that with some of the questions. Trying to take, you know, what you know about the medication and throwing it into taking care of a patient. So that type of thing. And then, you know, obviously knowing how they work. So, okay.